Welcome, good morning. Welcome to the next meeting of the President's Commission on Combating Drug Addiction and the Opioid Crisis. I welcome the members of the commission who have joined me here today, Congressman Kennedy, Governor Cooper, Governor Baker, Professor Madras, thank you for being here, and all of you who have come here today to help bring greater clarity to this issue. We appreciate you all being here. I want to first turn things over to I love this title, Designated Federal Officer. And that sounds important, Michael. So make it be important. Michael Passante from ONDCP, who's our designated federal officer, to do the orientation, and then we'll begin the meeting.
Thank you, Governor. I'd like to welcome everyone to the fourth meeting of the President's Commission on Combating Drug Addiction and the Opioid Crisis. The topic of today's meeting is insurance issues related to the opioid crisis. On the Commission's website, you can find the agenda for this meeting, minutes and videos of past meetings, and a copy of the Commission's interim report. That's at www.whitehouse.gov/ONDCP, and there's a link there to the President's Commission. The Commission plans to hold its fifth and final meeting here on Wednesday, November 1st from 1:30 to 3:30 p.m. Eastern Time, and issue its final report at that time. That final meeting will also be live streamed on www.whitehouse.gov/live. The public is also invited to submit written comments for the Commission's consideration by emailing them to commission@ondcp.eop.gov. So I'd like to thank Chairman Christie, the Commission members, Richard Baum, the Executive Director of the Commission, and Secretary Shulkin, Secretary Acosta, Secretary Hargan, Deputy Attorney General Rosenstein, and other federal agency representatives and witnesses. And with that, I will hand it back to Governor Christie, Chairman of the President's Commission.
Michael, thank you very much. Welcome to everybody. The commission members have been working hard on our final report, which will be issued on November 1st. I want to particularly thank Professor Madras, who, as I announced at the last meeting, is taking the laboring oar on drafting this report. And I can tell you from having read early portions of it, this is a report that I think will not only be comprehensive in terms of its recommendations to the President and the administration, but also extraordinarily instructive in terms of how we got here, which is an important thing for this commission to acknowledge. 64,000 deaths in the United States from this crisis, and a crisis that has been, in my view, self-inflicted. If we had 64,000 Americans being killed in some other way, I think that the reaction would be significantly different than it has been leading up to the establishment of this commission by the President. I think the President has acknowledged by establishing this commission how extraordinarily important this issue is and how devastating it is to American families in every state in this country. And so I want you to know that every one of the members of this commission are taking this extraordinarily seriously. And I can't thank Congressman Kennedy and Governor Cooper, Governor Baker, and Professor Madras enough for their extraordinary hard work. And we've got a lot more to do and a lot more to read and a lot more to decide in the next 11 days or so. So I thank all of them for their hard work, and thank you all for being here. We are fortunate to have a number of people from the President's cabinet and his senior staff here today to talk to the commission a bit. And then we have some other folks from the private sector who will be talking as well. So we've got a very full agenda. So we're going to get right to it. I want to start with the person who is the President's point person on this in the White House. She has been indispensable to me as the chairman of this commission in being able to get the resources of the White House available to us to be able to do the things that we need to do to make this report meaningful for the President and meaningful for the country. So Kellyanne Conway, Counselor to the President, thank you for your incredible hard work and the folks on your staff. And I turn the microphone over to you.
Thank you very much, Governor and Chairman, and members of the Commission. Thank you again for your hard work. We anticipate the final report, and we're all looking forward to finding the best way to implement that administration-wide. It is no accident that members of the Cabinet are here and stand ready to act on those recommendations fully as we move forward on an issue that really is touching every area of America. This is no longer someone else's coworker, someone else's community, someone else's kid. This is affecting everyone everywhere, and we are, as an administration, as a White House, beginning with the President and now the First Lady, putting a very significant effort behind educating Americans as to the crisis next door, the epidemic next door. And we believe that everyone is affected by the problem. We'll be calling upon Americans to join in on the solution. I would note publicly that a week from tomorrow is National Take Back Day. That occurs 2 times a year. So on October 28th, National Take Back Day. The more that everybody, members of the media, thank you for connecting America with the information it needs in this regard. The more people can make folks aware that they can bring back unused prescriptions, no questions asked, to any number of places. It's run by the DEA, but I would like to publicly urge folks to think about that and to encourage others in their circle of life, family, friends, colleagues, co-workers, and the like, to join and to participate there. I had occasion last week to tackle and to witness a different aspect of this crisis that we've not really touched upon here very much, which is I traveled with First Lady Mrs. Melania Trump to Huntington, West Virginia, to Lily's Place, a first-of-its-kind center in this nation where they're doing tremendous work in administering care to newborns who are born physically dependent on opioids and other drugs sometimes. And it was remarkable to see intervention, treatment, and recovery among our youngest victims of this crisis. So without taking anybody else's time, I would just like to thank everybody for being here, including representatives of the insurance industry, to find out how best your role fits in us moving forward, identifying the problem, finding the solutions. Thank you very much, Mr. Chairman.
Thank you, Kellyanne. Appreciate it very much. Another person who has been an extraordinary resource and advisor in the White House, both for the Commission and for the President, is the President's Assistant for Intergovernmental and Technology Initiatives from the Office of American Innovation, Reed Cordish. Reed and I have known each other for a long time, and he has been an incredible help as well to the Commission. So turn the microphone over, Reed, to you.
Thank you, Governor, and thank you to the Commission for your work to date and for your upcoming work leading to the final report on November 1st. Governor, you're right that it is important to look at how we got here. If we're going to fix the problem, we need to understand how it came to be. And this is a problem that has been building in this country for over a decade. And it's a problem whose trajectory is truly startling. And it's a problem that deserves the absolute highest attention of the government and of our citizens. And clearly, the creation of the President's Commission is a signal of that, as is the President directing his secretaries and our offices, our sub-cabinet, to treat it as one of the highest priorities of the administration. Men like Director Collins of NIH and Director Gottlieb of FDA, Secretary Shulkin of the VA are personally handling their agencies and their offices' response to this epidemic. And the administration has been moving aggressively based on recommendations of the interim report and recommendations of our cabinet secretaries. To give some examples, the FDA has been engaging aggressively with clinicians to change their opioid prescribing behavior to prevent addiction before it starts. And they've been working to develop over-the-counter naloxone for overdose reversal and taking steps to protect public health by removing dangerous drugs from the market where the public health risks outweigh the benefits. NIH has placed it as an absolute top office objective to come up and work with the private sector to come up with better cures and better pain addiction medicines. The Department of Justice has placed it as a priority, funding $50 million for drug courts and alternatives to incarceration for addicts. And the President has placed a priority on securing our borders to prevent illicit drugs from flowing into our country. And then lastly, the administration has called for the largest single sum ever dedicated to the opioid crisis in the form of state targeted response grants totaling $485 million. We eagerly await the final report. It has our highest attention, and we know that to solve this problem, we have to deal with it in a holistic manner, and that's what we intend to do. But thank you very much.
Reed, thank you very much. Appreciate your help and your comments today. Myself and Congressman Kennedy traveled with Kellyanne Conway to visit the Lewis Stokes VA Hospital in Cleveland, Ohio. It was a really eye-opening visit, and it was coordinated, organized, and led by the Secretary of Veterans Affairs. So for Secretary Shulkin, we thank you for the extraordinary amount of time you've already invested in the Commission's work, including that trip to Cleveland. And I turn the microphone over to you, Secretary Shulkin, for remarks.
Great. Thank you, Governor. I also wanted to join in and offer my sincere gratitude for all of the work of the Commission. I watched the way that you've dealt with this issue. You've taken it seriously. You've brought great public attention to this much-needed issue. And I think all of us eagerly await your recommendations so that we can implement it with an aggressive timeframe. This issue, of course, is very important to VA. 50% of returning combat veterans suffer from chronic pain and acute pain. 50%, close to 50% of our older veterans suffer from chronic pain. And so VA has addressed and begun to address this issue starting back in 2010. And I think VA has two particular contributions that we hope may be reflected in the report. The first is what we've done so far over the last 7 years that has resulted in a 36% reduction in opioid use. And that is, in VA, if it is meaningful, it has to have an acronym. So our acronym is STOP PAIN. S is for our stepped model of care. T is for our treatment alternatives like complementary care. O is for ongoing monitoring usage. P is for our practice guidelines that we've put out with the Department of Defense. The second P is for prescription monitoring. The A is for academic detailing. The I is for informed consents for patients. And the N is for naloxone distribution. We think that's a multifaceted way to address this issue because there's not one easy solution out there. So we certainly are very pleased to have been able to share our experience of what we feel has worked. I think the future of where VA is investing is in a new way of delivering health care, and that's what we call the whole health model of health care. And this is really empowering our veterans with the decision-making to make the best choices for themselves and to really own and be accountable for their own health care. So under this model, what we're doing is we're bringing in groups of veterans at the beginning of their entry into the VA system in a peer-to-peer approach and teaching them how to be more knowledgeable, informed, and empowered in being responsible for their own navigation of the healthcare system. And in this, we're teaching them tools that are very helpful, particularly in pain management, like the use of complementary therapies, mindfulness, and how to ask and be informed in the right questions. So we believe that part of the future solution should include a holistic approach to navigation through our complex healthcare systems, because I think, Governor, as you said, this is really a symptom of the failures of the American healthcare system, the gaps in care, the fragmentation in care, patients in some cases, trusting too much these decisions to other people, and then they become addicted. So thank you very much.
Secretary Shulkin, thank you. A decade ago, I had the opportunity to work as a fellow United States attorney with Secretary Acosta. He in Miami, me in New Jersey, and I grew to have great respect and affection for Alex and was thrilled when the President named him to be Secretary of Labor. And very happy to have the opportunity to have him here today. Some of you may wonder, why is the Secretary of Labor here? There's a whole bunch of crossovers for labor that you'll learn more about today. And we have a person who I know knows how to take a very aggressive approach to solving problems as our Labor Secretary. We're lucky to have him. So turn it over to you, Alex, for remarks.
Governor, thank you. And it's nice to recall the days when you, I, and Rod here were U.S. attorneys, and so it's great to be working with you again. As you mentioned, there are a number of crossovers, and I'd like to approach the opioid issue from three different perspectives, because the Department of Labor looks at this as a workforce issue, but we also have about 2 million individuals through the workers' compensation programs for whom this is an issue, and we're also a regulator and enforcer vis-a-vis insurance policies. And so I'd like to take each of those in turn. First, as a workforce issue, nationally, our unemployment rate is 4.2%. That is amazingly low, the lowest in nearly 17 years. So that's great news on the one hand. On the other hand, labor force participation has been dropping since 2007. And it is at a fairly low number. And so one of the questions is why? Why are so many people not in the labor force? And I want to answer that by citing the chairman of President Obama's Council of Economic Advisors, because I really do think opioids should be a bipartisan issue, and I want to cite him to sort of create bipartisanship around this. He recently came out with a study, and he looked at a Bureau of Labor Statistics survey, the American Time Use survey, that found that 44% of prime-age males 25 to 54, who were not working, had taken a painkiller the prior day. Not the prior week or the prior month, but the prior day. 44% of males outside the labor force in prime working years. And so he said this is a very high number. So let me do a more in-depth survey. And he went back and he asked, what kind of painkillers did you take? And he found that a high percentage of them, 2/3 of those, had taken prescription pain medication the prior day. So in essence, 31% of prime-age males not in the labor force took prescription pain medication the prior day. Now, there are approximately 94 million Americans not in the labor force. What number of those are men? And of those, 31% the prior day took a prescription painkiller. So if we want to look at labor force participation rate, this is the number one issue. And that's according to the prior chairman of the President's Council of Economic Advisors. He estimated that 20% of those individuals not in the labor force were not in the labor force because of opioids. Secondly, the Office of Workers' Compensation. Through the OWCP, we cover more than 2 million federal employees and others through our Office of Workers' Compensation program. And so, as a result, we can set parameters, and we did something this past June. We required prior authorization and a letter of medical necessity for opioids. We had a very quick spike. People wanted to get their prescription before we required this, and then a massive drop-off. A very, very sharp, drastic drop-off to almost none. Now, it's going to come back up a little bit, and we're waiting to get the data because we just put this in place 2 months ago. But something as simple as prior authorization and a letter of medical necessity among these 2 million individuals has changed behavior substantially. And I think that's something that's worthy of consideration, and we're keeping the data. And by December, I think we'll have enough time that has gone by that we'll have good data on how much this has impacted. But that really does tell you information both about the necessity and how small actions that government can take can have substantial impact. Thirdly, EBSA, which is one of our sub-agencies, the Employment Benefits Sub-Agency. And EBSA has jurisdiction to maintain, to enforce the parity law that ensures that Americans receive benefits they're entitled to with respect to substance abuse. And EBSA works very hard. It cited more than 300 employers for non-compliance. And so it is enforcing this non-parity law. But there are 2 points that I want to make. One, under the non-parity law, there are no civil fines. And so those that have been in enforcement understand you can cite someone for non-compliance, but if there is no fine, I'm a big believer in compliance assistance. I'm a big believer in the carrot. But along with compliance assistance and a carrot, you have to have a negative outcome if folks don't want to work with you, right? And so there is no fine. The second point I'd make about the way that this is enforced is it is enforced under current law employer by employer. And so we've actually gone to several insurance companies in this room, and we've worked with you, and you have assisted us in making sure that your employers are complying. But we have no enforcement authority as against the insurers themselves. And so we're having to go employer by employer by employer, as opposed to the much more efficient approach, which is to work directly with the insurance companies that have thousands and thousands of employers that they're working with to ensure that there is parity. And so I want to highlight that because as the commission does its work, it's something that I think the commission should consider. What is the most efficient and effective mechanisms? And finally, let me say, I think the vast majority of folks want to do the right thing here. And I think if there's an issue here, it's an issue around lack of knowledge, lack of sort of thinking it through, because people want to do the right thing. Because, reducing the number of opioids is a win-win across the board. It's a win for the individual who doesn't want to get hooked, and once they're hooked, they want to get off it. It's a win for the insurance companies who don't want to be paying for medicines that people don't need, and it's a win for the American workforce. Because if we can get people back to work and paying taxes and participating fully, that's a win for them and it's a win for the country. And so I thank you for your time and I thank you for your focus.
Alex, thank you. And I think that the two issues that you pointed out in your third point are ones that are of not only particular concern to the commission, but most particular concern to Congressman Kennedy. And so I would hope in the period of time we have left that you and the department would be willing to work with Congressman Kennedy as our designee to drill down on those and make sure that if there are recommendations the commission wants to make, they're ones that are in line with your department's desires and your ability to be most, as you said, effective and efficient.
Gladly.
Thank you. Appreciate that. Next, Acting Secretary of HHS, Eric Hargan. Eric, thank you so much for coming. We appreciate it very much. And obviously, HHS is a huge part of dealing with this issue. And so turn over to you for remarks.
Thank you, Governor. Obviously, HHS, I could probably spend the rest of the time you have here just going through the list of things that, the roles that HHS has to play in combating the opioid crisis. We have a number of subcomponents that are going to be, that are and continue to be very active in all different aspects of addressing this. We have overall strategy, but we also have within our components, National Institutes of Health have been obviously very active in developing treatments and treatment modalities that can address at the individual clinical level. We have SAMHSA, our Substance Abuse and Mental Health Services Administration, that's sort of front and center in dealing with issues of substance use and abuse. So, and they have developed a lot of innovative practices, and the new head of SAMHSA is someone who is sort of comes from the entire background. In fact, having been at SAMHSA before, as chief medical officer, having worked at the state level on a number of different aspects of this issue, is pretty much an ideal leader for SAMHSA for this exact issue. And she's also been a practitioner who was dedicated to the issue of substance use and abuse. So from her point of view, she actually comes with a clinical background in this exact area. So we're actually pretty fortunate to have her as one of the leaders of one of our agencies, one of the ones that's going to be most forward-facing and public-facing for this issue. Also, we have the FDA, obviously, which has also been targeted as one of the main response agencies for us, dealing also with developing not just with helping sort of industrialize and bring to use and bring to the bedside the treatments that are going to be developed by private sector as well, and also helping to work with DOJ as they always end up on the front line in terms of interdiction in many cases and finding out where we get shipments in and issues on that front. We also have HRSA, which runs a lot and funds a lot of the places where the opioids we think are accessed. So down in the communities, the community health centers and areas definitely are going to be part of the solution here, and HRSA's monitoring on this. And even, well, of course, CMS and the payment that Alex was referencing. Obviously, CMS is the largest payer and either through Medicare or through its partnership with Medicaid and working with the state Medicaid agencies to work on how we can address that, not just from the medical point of view at NIH, not from the product point of view at FDA, not through the actual addressing of the substance abuse through SAMHSA, but also through the payment issues that, as Alex pointed out, it can be pretty central to finding out where and how we can address this. And also, in fact, monitoring where that's being accessed and where we're having real problems with opioids being taken up. In fact, I can't name a component of the department that doesn't have a role to play here. Even the Office of the National Coordinator of Health IT has been working with some of our other agencies and the state agencies to help work with software that's going to monitor easily where we get prescription drug use, particularly across state lines, where we have people sort of going across state lines, and through the PDMP plans that we've developed on that front. So, as I say, I will keep it as short as that because I don't think I think we could spend all day here with me walking through everything that we're doing at HHS. Thank you, Governor.
Secretary, thank you very much. Appreciate you being here, and know that HHS is going to be an enormous part of our ability to deal with this problem, and appreciate you recognizing that as well. Continuing the Bush 43 U.S. Attorney alumni roll call, I turn to the Deputy Attorney General of the United States, Rod, who spent 12 years as the U.S. Attorney in Maryland and did an extraordinary job there, and is now has what I've always believed is the most difficult job in the Department of Justice, which is to be the Deputy Attorney General and make sure that the running of that office is all of its components. And so he has extraordinary responsibility for law enforcement across the entire country, and we are in very, very good hands with that authority and that responsibility being with Deputy Attorney General Rosenstein. So, Rod, it's good to see you again.
Thank you.
Turn it over to you.
Thank you, Governor. I did have the great fortune to work with you and Secretary Acosta in the aftermath of the September 11th terrorist attacks many years ago. We then worked together as U.S. attorneys on Project Safe Neighborhoods, which brought historic reductions in violent crime. So we know the impact that law enforcement can have. And your New Jersey State Police, in fact, have been a leader in developing a comprehensive program to combat opioid abuse. So I know firsthand the tremendous leadership that you bring to this effort, and I want to thank the Commission for your commitment to helping us solve this problem. The opioid crisis is a result of three types of substances. The first is prescription painkillers, which get a lot of attention. The second is heroin, which has long been a problem. And the third is a relatively new phenomenon known as fentanyl, which is a synthetic opioid drug. There's no doubt that overprescribing of pharmaceutical drugs is a primary contributor to the opioid crisis. But today we face a new and disturbing facet of the crisis. More and more of our citizens are being killed by fentanyl. This synthetic opioid is far more lethal, far more dangerous than heroin. More than 20,000 Americans died of drug overdose deaths in 2016 with fentanyl in their systems. And we believe that fentanyl, imported from China, is a primary cause of the recent surge in opioid overdose deaths. In addressing the role of pharmaceutical drugs in the opioid crisis, we must be cautious about unintended consequences. For example, medically assisted treatment certainly can help people defeat addiction, but the most common medications used in treatment are also opioid drugs, which are prone to abuse and diversion. We have reports about treatment clinics that themselves can resemble pill mills. So because treatment is so important in solving this crisis, we need to be vigilant to prevent bad actors from hijacking that system and exploiting the solution to the opioid epidemic. The use of medication-assisted treatment in jails and prisons poses unique challenges. Incarceration gives us an opportunity to keep prisoners from abusing drugs and to prepare them for a drug-free life on the outside. Several cases prosecuted in my home state of Maryland highlight the risk of diversion and abuse of opioid drugs like Suboxone, which also is highly addictive. So treatment is important, but treatment alone is not the solution. We need to focus on prevention. If you want to stop cars from speeding, you can post speed limit signs. You can run advertisements about the risks of speeding. But the most important and effective form of prevention is to actually enforce the laws. and the Department of Justice specializes in law enforcement. Enforcing our laws helps to prevent unlawful prescribing of highly addictive drugs and thus the creation of future addicts. It also helps to keep heroin and illicit fentanyl out of our country and away from our children. Opioid addiction is different than most public health problems because it doesn't spread on its own. Fentanyl reaches victims only if people produce it in labs, people ship it across borders, and people distribute it to users. So we can stop it if we prevent and disrupt any one of those pathways. Drug overdose deaths rose by about 50% from 2011 to 2016, but federal drug prosecutions fell by 33%. Aggressive enforcement of our laws is an essential part of the solution of this crisis. But consistent with President Trump's goals, Attorney General Sessions is committed to restoring federal drug enforcement. We are not devoting resources to prosecuting low-level drug dealers. We are focusing on disrupting drug supply chains. The department recently announced the largest healthcare fraud takedown in American history. We arrested more than 400 defendants, including doctors and medical professionals. We also created an opioid fraud and abuse task force. This is a unit that's committed to investigating and prosecuting opioid-related healthcare fraud. And we recently dismantled the largest internet website that was committed to and used for the sale of illegal drugs. Now, most fentanyl comes from China, and we're taking steps to disrupt that supply chain. I visited China last month and met with leading Chinese law enforcement officials to discuss what we can do working together to disrupt Chinese manufacture and distribution of fentanyl. On Tuesday, the Department of Justice announced for the first time charges against major Chinese traffickers of fentanyl. And in September, our department announced almost $60 million in grants for state and local law enforcement, state and local treatment of opioid abuse. So the Department of Justice is fully engaged in this effort. And I want to thank the Commission for your commitment and your efforts on this initiative. The Department of Justice looks forward to continuing to work with you to protect the American people from the devastation of opioid abuse. Thank you, Governor.
Rod, thank you very much. I want to thank all the members of the President's senior leadership who gave remarks, and hope that you'll all stay with us. I want to give our invited guests an opportunity to make their remarks as well, and then give Commission members the opportunity to ask questions of all of the folks around the table that have contributed remarks today. So I thank the President's senior leadership for being here and for your efforts. First, I want to go to Marilyn Tavener. Marilyn is the President and CEO of America's Health Insurance Plans, and I turn it over to you. Thank you for being here, Marilyn, and turn it over to you for remarks.
Thank you, Governor Christie, and members of the Commission for inviting us here today. And thank you for your leadership in this very severe problem that we are all interested in immediately addressing. I won't go back through the statistics because I know that the members of the Commission know them as well as anyone in this room. And so I'll not repeat any data, but what I'll do is go directly to the commitment that the health plans have to helping solve the problem. And it is something that we worry about both from the standpoint of our role in between employers and the community, our role in between employers and their individual employee. And this is going to take action by all the individuals that you have here today if we're going to dramatically reduce this problem. So let me start about some of the action steps that we have taken. We've been engaged both at the federal and state level with leaders, with doctors and hospitals, with community organizations, and many others. And I think it's important that this is as much about education and support as it is about prescription control. So we have looked at other ways of treating chronic pain that work, that are not just the substitution of one drug for another. We've tried to understand the crisis and develop strategies working with our communities in order to address it. We've tried to understand prescribing patterns and how they may affect dependence on addiction and ensure patients struggling with addiction get the treatment and the support they need. We support, let me start by saying, going back to HHS, we support the CDC guidelines for when and where to prescribe opioids, which also includes prescribing non-opioid medication first, limiting both the dosage and the duration of prescription opioids, and reviewing a patient's medical history to look for signs of addiction. We also support and review the latest medical research to find better ways to manage pain and adopt new evidence into developing coverage policies for pain management treatment. Our plans have robust checks and balances in place to ensure that patients get the right medication and the right dosages. And these include things like building high-quality provider networks, and I cannot stress that enough. If you're dealing with quality physicians and pharmacies, then some of the problems that law enforcement talks about go away. So we work with credentialed doctors, pharmacies, and facilities. We have a sequenced approach which guides patients through evidence-based pain management before prescribing an opioid. We do require prior authorization for opioids, so plans' clinical experts can work with their individual physicians to ensure that they are adhering to evidence-based protocols and offer the most effective treatments. And when the opioid is prescribed, we work to do the lowest dosage and shortest duration to effectively treat the individual's plan. We also analyze their data to try to identify potentially concerning prescribing patterns that trigger further review. We are making progress, and we strongly agree that more can and must be done. And that's why our teams are implementing programs that work at finding new solutions. And I go back to Secretary Shulkin. We released an initiative yesterday called STOP, not Stop Pain, but STOP. So we are aligned. Yes. Our STOP stood for Safe, Transparent Opioid Prescribing. And this initiative really supports widespread adoption of clinical guidelines by all of our plans with the idea of making sure that we're following guidelines for pain care and for opioid prescribing. Our first piece of this, obviously, is making sure that we have data available on how plans are adhering with provider practices that match the CDC guidelines, because that's a good place to start. And if you can get all the physicians and all the plans supporting that, that goes a long way. We've also engaged with Pew Charitable Trust and Shatterproof to discover new ways to improve treatment for those with substance use disorder. And I know that we have many leaders here today, and so I'm going to make my comments short, but I will say I think we have some of the brightest people in this room. They represent plans across the country, large CEOs of health plans, small CEOs, physicians who serve as chief medical officers, pharmacy directors, and government and state relations. And so I hope that we'll give you some good ideas today. We all agree that this has not one solution. It's a multifaceted approach. We'll need more research to find alternative ways to treat pain. We need more pain specialists, which gets back to the HRSA and workforce issue. And we need more providers who are equipped and well-trained to help those going through the treatment and recovery process. We are actively engaged with social service agencies, state Medicaid programs, healthcare providers, pharmacists, and pharmaceutical companies to find more solutions. Again, we appreciate this opportunity to engage today and look forward to the questions. Thank you.
Marilyn, thank you very much. Appreciate it. Next to Pamela Greenberg. Pamela's the President and CEO of the Association for Behavioral Health and Wellness. We appreciate you taking the time to be here today and look forward to your remarks.
Governor Christie and members of the Commission, thank you for inviting me here today. As the Governor said, my name is Pamela Greenberg, and for the last 19 years, I have served as the President and CEO of the Association for Behavioral Health and Wellness. ABHW member companies provide specialty services to treat mental health, substance use, and other behaviors that impact health and wellness to over 170 million people in both the public and private sector. Our members include both specialty behavioral health organizations and health insurance companies. I'd like to start by reminding everyone that addiction to opioids or other substances is a chronic illness, not a bad habit or a failure of will. If we can shift the public's perception and eradicate stigma associated with substance use disorders, we can make progress in helping people feel comfortable sharing their personal stories and seeking the treatment they need. ABHW and its member companies run a campaign, Stamp Out Stigma, and the goal of that campaign is to do just that. ABHW and its members are committed to helping defeat the opioid epidemic. Our members work to identify and prevent addiction where they can, and where they can't, they help individuals with an opioid use disorder get the appropriate treatment to recover and lead full, productive lives in their community with their families and loved ones. Today, I will highlight 3 areas our member companies focus on to address the opioid crisis. I will also touch on a few ABHW's recommendations to the Commission for your final report. All of our recommendations are included in my written statement that I've submitted for the record. First, the identification of individuals at risk of opioid dependence is a critical step in helping stop opioid overdose and death. To do this, some ABHW members employ drug utilization review programs. These programs flag members who are being treated for opioid dependence but are still filling opioid prescriptions. DUR programs notify a pharmacist when individuals are also filling opioid prescriptions at another pharmacy or have prescriptions for other drugs that may have a counter interaction with their opioids. Other companies analyze claims data to detect opioid use patterns that suggest possible misuse by individuals, and then they reach out to the person or notify their healthcare provider about the situation. Second, we are all painfully aware that there are an inadequate number of qualified substance use treatment providers. ABHW members build provider networks in a manner that helps ensure that they have capacity to meet the needs of their consumers. Some companies have also found peer services and community supports to be useful in helping people engage and remain in treatment. At least one member company partners with Project Echo, a telementoring platform that links specialists with non-specialists through virtual clinics. The specialist mentor helps educate providers about the latest advancements in evidence-based care and improves access to treatment. And third, every 25 minutes, a baby is born suffering from an opioid withdrawal. ABHW member companies follow established standards of care for newborns with neonatal abstinence syndrome. One example is a company that identifies pregnant women with a substance use disorder and engages them in case management. If allowed, the infant is also followed for at least a year. Our first recommendation for the Commission relates to 42 CFR Part 2, an outdated regulation that limits the use and disclosure of patient substance use records. This regulation severely constrains the healthcare community's efforts to coordinate care for persons with substance use disorders. And ABHW members say Part 2 is one of the biggest, if not the biggest, barrier to fighting the opioid crisis. We urge the Commission to support aligning Part 2 with the treatment, payment, and healthcare operations language in HIPAA through a legislative fix or pending regulatory guidance. Second, very few states permit Medicaid managed care organizations and private health plans access to prescription drug monitoring program data. If allowed access, these entities could identify patients at risk of overdose or complications and become a strategic partner in preventing and identifying abuse. The Commission should instruct each state to have a PDMP, which health plans can access, and which allows information to be exchanged across state lines. The creation of a national PDMP would also be useful. Third, ABHW recommends easing the burden on primary care providers willing to prescribe MAT. Development of educational resources and additional training will help make PCPs more comfortable with MAT. Another idea is to provide incentives to encourage PCPs to take care of their own opioid-dependent patients. Fourth, the standard of care for opioid use disorder is to treat the disease with a combination of medication and evidence-based psychosocial interventions. As such, ABHW suggests creating a mechanism to ensure providers are practicing in accordance with national standards, such as the American Society of Addiction Medicine's National Practice Guideline. Finally, given the rise in the opioid epidemic and the growing shortage of behavioral health providers, the expansion of telehealth is an important option for the Commission to consider. A significant barrier is the Ryan-Haight Act. ABHW recommends making changes to this law to eliminate the requirement of face-to-face evaluation. Additionally, removing the restrictions to Medicare reimbursement of telehealth would provide better access to treatment to Medicare beneficiaries. Thank you for the opportunity to speak to you today. We hope that you will include our recommendations in your final report, and we support the goals of the Commission, and we are committed to working with interested parties to help eradicate the opioid epidemic in this country.
Pamela, thank you very much, and thank you for your recommendations, and you can be assured that we will give them real consideration as we put together the final report. Next, I want to turn to some of our other invited organizations and the folks who are here representing them. We first want to say how much we appreciate you all taking the time to be here today and to share your experiences with us. Very, very important for us to be hearing from as many constituencies as possible on this. because it's going to take all of us to deal with this problem. I want to turn first to Dr. Harold Paz, who's the Executive Vice President and Chief Medical Officer of Aetna. As you can tell from our focus today, our insurance companies are going to be a very, very important part of whether we're able to stem the tide here or whether we're not. And so I'm going to turn it over to you, Dr. Paz.
Well, thank you very much, Governor Christie and members of the Commission, for the work that you do in bringing attention to the opioid abuse epidemic and for pulling together a diverse set of healthcare stakeholders to identify and propose solutions to this terrible crisis. I appreciate the opportunity to share Aetna's perspective on this critical public health issue. I serve as the lead of Aetna's enterprise-wide opioid task force. Aetna is a leading diversified health company that provides individuals, employers, and healthcare professionals and others with innovative benefits, products, and services. And we serve over 46 million individuals in the United States and around the world. Aetna's strategy is to build a healthier world and to help individuals achieve their unique health ambitions, in part by addressing the holistic needs of each individual, physical, mental, and social well-being. Addressing holistic needs for our members is even more important when we look at those that are afflicted with addiction and behavioral health concerns, which is why I'm proud to say that Aetna is committed to working tirelessly to help reverse the devastating trend of opioid addiction and abuse. Aetna is taking a comprehensive and holistic approach to addressing the opioid epidemic. Our three-pronged strategy is focused on preventing misuse and abuse, intervening when we identify at-risk provider and member behavior, and supporting members by providing access to evidence-based treatments. In order to protect our members and assist those struggling with addiction to regain their lives and to restore their dignity, we're holding ourselves accountable as a company by committing to 3 ambitious data-driven goals. By 2022, we're committed to 1, increase the percent of members with chronic pain treated by an evidence-based non-opioid option by 50%. Second, reduce the percent of inappropriate opioid prescribing for our members by 50%. And third, to increase the percent of members with opioid abuse disorder treated with medication-assisted therapy and other evidence-based treatments by 50%. Consistent with the Commission's recommendation for greater provider education, Aetna is taking a proactive approach, working with providers to reduce opioid prescribing, misuse, and abuse. And we're using considerable data resources to encourage prescribers to reduce misuse and prevent diversion of unused pills. Starting in 2016, I began sending letters to the top 1% of opioid prescribers within their respective specialties to alert them to their prescribing pattern. These 1,000 opioid superprescribers were also provided the CDC guidelines regarding appropriate opioid use in the treatment of chronic pain. This program continued this year with separate outreach to dentists and oral surgeons. In May, we identified and sent letters to more than 700 superprescribing dentists and oral surgeons. This effort was in collaboration with the American Association of Oral and Maxillofacial Surgeons. We're now rerunning our analysis and planning more aggressive interventions for those providers who haven't improved their opioid prescribing habits over the past several months. For most of our members, opioids should not be the first choice for treating pain. We're working to encourage our members to explore alternatives prior to taking opioids. That includes ensuring our products appropriately cover evidence-based non-opioid treatment options and working with stakeholders from across the healthcare ecosystem to incentivize greater options for consumers. This past month, we announced a partnership with an innovative New Jersey-based pharmaceutical company and the American Association of Oral and Maxillofacial Surgeons to provide an alternative to opioids for our dental members following wisdom tooth extraction. By providing safer alternatives for pain control, fewer opioids are prescribed, and we avoid the risk of misuse and diversion of unused pills. We cannot simply reduce generic opioids with abuse-deterrent opioids. We need to promote holistic treatment options that include non-opioid therapies such as non-steroidal anti-inflammatory drugs, acetaminophen, as well as non-pharmacological modalities such as physical therapy, acupuncture, and chiropractic care when medically appropriate. The federal government has a critical role to play in addressing this epidemic. First, we believe that federal legislation and regulations should be modernized to provide healthcare organizations the flexibility to confront this epidemic. We strongly support the Commission's recommendation to modernize privacy regulations. 42 CRF Part 2 to allow greater data sharing and coordination to prevent opioid overdoses. Current Part 2 regulations prevent health plans and providers from sharing information needed to treat members with addiction. Furthermore, the federal government should provide greater resources to states to support programs addressing neonatal abstinence syndrome. Newborn babies are the most vulnerable victims of this terrible epidemic. The federal government can play a role in increasing attention and resources to ensure that pregnant women are screened properly for opioid abuse and treated for opioid addiction, and that newborn babies with NAS receive the care and support that they desperately need. We also believe more can be done to prevent inappropriate practices, fraud, waste, and abuse. This includes requiring electronic prescriptions for all opioids, developing a national prescription drug monitoring program, and providing health plans greater flexibility in the Medicare program to crack down on inappropriate practices. And finally, it's important to recognize that as we reduce the supply of prescription opioids, we're not solving the addiction crisis. Where there's demand for opioids, there will be supply in the form of illegal manufactured fentanyl, as you heard earlier, and heroin. That is why we need to focus on expanding the number and quality of addiction treatment options, and with the support of the federal government, greater law enforcement action to reduce the supply of illegal drugs. Aetna is committed to working to reverse the trend of opioid use and abuse across the nation. We'll continue to enhance our programs and to reduce opioid prescribing, increase non-opioid pain treatment options, and promote evidence-based recovery for our members with addiction. We look forward to continuing the dialogue with the Commission and other policymakers to find solutions to this epidemic. Thank you again for your leadership, and thank you so much for having Aetna here today.
Doctor, thank you very much. Appreciate your remarks. I want to turn next to Joseph Swedish, who's the Chairman, President, and CEO of Anthem.
Great, thank you, Governor Christie and distinguished members of the Commission. It's an honor, truly an honor, to be with you today to discuss how we can collectively work together across the entire healthcare system and beyond to combat drug addiction and address the opioid crisis. With over 1 in 8 Americans served by our affiliated companies with whom we work closely to manage their health care, we've built programs upon a foundation of quality to improve their outcomes. With this underlying approach to a major health care issue, I'd like to share just a portion of the extensive actions Anthem is taking to address the opioid crisis, a crisis that crosses all demographics and impacts commercial, Medicare, and Medicaid programs, and one that we are meeting head-on through our holistic strategy centered around prevention, treatment, and recovery, and deterrence. Just last month, we announced our success in reducing opioid dispensed to our members by 30% from the historic peaks in 2012, more than 2 years earlier than forecasted. But we're not stopping there, and we've just substantially increased that goal. We've aligned our pharmacy benefit strategies with CDC guidelines, limiting initial short-acting opioid prescriptions to 7 days, and put in place prior authorization for all long-acting opioids. Treatment and recovery work hand in hand, and our approach extends beyond traditional medications and care programs. Many individuals facing addiction also have coexisting physical and mental health conditions. So we're working to provide integrated care for all of our members. Non-opioid pain management is truly a component of a holistic approach. We support coverage of pain relief, drugs, and non-drug treatments according to best clinical practice guidelines and scientific evidence, including CDC guidelines. There are many non-opioid approaches that we cover, both non-opioid medications and non-drug treatments alike. We don't require prior authorizations for the use of naloxone, a life-saving emergency drug, and we've eliminated prior authorization for certain drugs used in medication-assisted treatment. We're working to double the number of members who receive medication-assisted treatment, along with the behavioral health support services, and we're improving access to medication-assisted treatment in rural and underserved areas by providing technical assistance and training to providers so there's at least one medication-assisted treatment trained physician in each primary care practice. In this regard, I want to emphasize the importance of taking evidence-based care to providers by way of training and then paying providers to do the right thing, which we do through a variety of value-based payment arrangements. We're supporting peer recovery services through partnerships with organizations like Aware Recovery Services in Connecticut and New Hampshire, who provide comprehensive in-home substance use disorder treatment services. We've also extended access to care and treatment through telehealth. Live Health Online, our telehealth program, permits individuals to access physicians at any time of day, 365 days a year, and now includes opioid disorder treatment and medication-assisted treatment through our partnership with Bright Heart Health, who provides online addiction support services for substance abuse. We're accelerating best practices in local communities, such as funding and supporting an extension for the Community Healthcare Outcomes Project in West Virginia, which connects primary care providers with expert medication-assisted treatment information to treat individuals with substance abuse disorders. And we're partnering with NICU facilities and their providers to establish care practices that follow established standards of care for newborns with neonatal abstinence syndrome, which occurs in newborns exposed to addictive opiates in the womb, while encouraging non-pharmacological treatment, parental involvement, and protocols to decrease the severity of symptoms and improve outcomes. As part of our efforts to address the fraud and abuse element of the opioid epidemic through deterrence, we operate a pharmacy home program across our commercial, fully insured, and Medicaid lines of business. This program assigns individuals who meet certain criteria related to opioid utilization to one pharmacy and one provider to receive their opioid prescriptions. This program allows physicians to monitor for dangerous combinations of medications and access to opioids and help ensure members are receiving counseling and mental health support. We've seen this program reduce hospital and emergency room admissions, increase the number of individuals in substance abuse treatment in some states, and reduce cost of care. We also have a range of strategies that leverage data mining and analytic capabilities to identify and address instances of opioid fraud and abuse, as well as diversion. Anthem's Special Investigative Unit contains a team of professionals trained to combat fraud and abuse utilizing a variety of methodologies. While we're proud of our success, we recognize we can do more and should do more to address this crisis. As we look to further expand our collective efforts, we recommend the Commission consider the following. First, work with stakeholders to address the shortage of qualified substance abuse disorder treatment providers and licensed healthcare professionals trained to support individuals with substance abuse disorders in the community, utilizing evidence-based models. Second, continue to develop more tools to educate patients with chronic and painful conditions on proper use of pain medications given the lack of accessible pain medicine specialists and trained primary care providers. Third, invest more resources dedicated to research for establishing more evidence-based treatment guidelines and innovative payment models. And finally, improve data and health information sharing to facilitate better care, which would include changing 42 CFR Part 2 to align with HIPAA, which will allow addiction history to be shared amongst treating providers. permitting Medicaid and commercial health plans to access prescription drug monitoring programs, and sharing Medicare fee-for-service Part A and Part B data with standalone Medicare prescription drug plans. Thank you for the opportunity to share our thoughts today with you to address this crisis. I look forward to more discussion today as well as continued work partnering with all of you going forward.
Thank you, sir. Appreciate that very much. And as I continue to be, unfortunately, the monitor of time here, I want to try to remind everybody who's going to present stuff to us today that, you know, we'd asked everybody to kind of give us their highlights and give us 5 minutes. I've got, I think, another 7 representatives I want to hear from before we get to ask you any questions. So I don't want any of us to wear each other out in the process. Kim Holland is from Blue Cross Blue Shield Association, Vice President for State Affairs. Thank you for being here, Kim, and I turn over the microphone to you.
Thank you, Governor Christie, members of the commission, and honored guests. I lead our system-wide efforts to respond to our country's opioid crisis. It is indeed one of the most pressing issues, public health issues facing our nation today, and our own data bears that out. Our recent Health of America report on opioid prescribing, which is being made available to the commission, reveals that our Blue members diagnosed with an opioid use disorder spiked 493% between 2010 and 2016. On behalf of the association, thank you for the opportunity to join in this discussion. Blue Cross and Blue Shield companies are strongly committed to doing our part to combat the epidemic of opioid use disorder. We very much appreciate the actions you are taking to bring all stakeholders to the table, as it will take all of us working together to bring about the needed systemic change. You've heard from Mr. Swedish of Anthem, and we'll hear from Dr. Anu Patel of Blue Cross Blue Shield of North Carolina, 2 of the 36 plans within our system who are leading and engaging in collaborative initiatives to address this crisis in their local communities. Just as states' needs will vary, plan initiatives will vary in response. However, since early 2016, Blue plans have convened their mental and behavioral health, medical, and pharmaceutical experts with a shared goal of adopting policies and practices that ensure appropriate opioid prescribing, promote evidence-based treatment for substance use disorder, and reduce the occurrence of fraud and diversion of prescription opioids. As evidence of this unified commitment, allow me to offer a few examples that speak to some of the Commission's interim report recommendations. We support prescriber education initiatives. Blue plans have endorsed the CDC guideline for prescribing opioids for chronic pain and are working collaboratively with the prescriber community to implement these or similar guidelines. For instance, Blue Cross Blue Shield of Massachusetts has instituted a program which implements best practices for prescribing opioids, including, among other practices, a treatment plan between the patient and prescriber outlining responsibilities and behaviors on both sides. A CDC study has praised the program, finding that it lowered the average monthly rate of opioid prescribing by 15%. And Dr. Patel will tell you about their successful prescriber outreach program in North Carolina. We support access to medication-assisted treatment. Blue plans cover medically necessary MAT and the associated counseling or behavioral therapy. Plans recognize substance use disorder as a chronic disease that should be treated as such. Plans work with physicians to ensure patients get the right care in the right setting at the right time based on each patient's individual needs and circumstances. And we're funding research in hopes of uncovering new insights that will lead to better treatment and prevention efforts for substance use disorder. We support wide availability of naloxone. Blue companies cover naloxone for members, and medical claims for naloxone have increased significantly over time. Additionally, many plans provide community funding for naloxone, ensuring access to all who need it. As one example, over the last 2 years, Capital Blue Cross in Pennsylvania has committed a total of $200,000 to fund the purchase of naloxone for municipal police departments. And we support enhanced operability of prescription drug monitoring programs. We encourage additional support to states that would improve the effectiveness and ease of use of PDMP systems. Currently, 37 states mandate some type of prescriber use under some circumstance. However, not all states allow physicians access to PDMP data before prescribing, and only one state permits health plan access to PDMP data. I would echo Ms. Greenberg and suggest that during the inevitable evolution of improved data sharing, health plans can serve as another resource. Analyzing PDMP patient data in conjunction with the plan's own provides a full picture of prescription drug utilization. Although Blue plans carefully monitor opioid use and potential misuse, there is a limit to what our data can tell us. For instance, if someone pays cash for a prescription drug, a claim is not generated. Access to PDMP data will fill in these blanks and promote more effective interactions with physicians to ensure a patient's safety as well as appropriate treatment. We support legislation to better align patient privacy laws specific to addiction with the Health Insurance Portability and Accountability Act. The association joined over 35 healthcare stakeholder organizations in a letter urging Congress to support Jesse's Law and amend 42 CFR Part 2 to align with HIPAA privacy regulation, access, and use requirements. And we support mental health parity and addiction equity. We believe all Americans should have access to high-quality, affordable health care and coverage. Plans are vigilant in their compliance with the MHP AEA and offer comprehensive benefits that include access to evidence-based mental health and substance use disorder treatment. We have strongly opposed changes to any existing law that would erode comprehensive health coverage and not provide robust mental health and substance use disorder benefits. In closing, Blue Cross Blue Shield Association and member plans share your commitment to addressing America's opioid crisis and ensuring that those suffering with opioid use disorder get the care they need to place them on a path to recovery. Thank you so much.
Appreciate it very much. Now we'll turn to Dr. Nur Patel, who's the medical director from Governor Cooper's home state of Blue Cross Blue Shield of North Carolina. We are happy to have you here and appreciate your willingness to give us some information today. Dr. Patel.
Good afternoon, and thank you to the members of the commission and everybody here for having us here from Blue Cross Blue Shield of North Carolina as part of this important discussion. As Governor Christie mentioned, my name is Anura Patel. I'm a physician. I'm board certified in physical medicine and rehabilitation. Prior to joining Blue Cross of North Carolina, I was in private practice doing pain management and treating addiction with medication-assisted therapy. I feel uniquely positioned and fortunate to be here because I've seen the devastation from the opioid crisis from both sides, both as the provider prescribing the medications and treating the addiction, as well as now from the payer side. I'm currently on the Blue Cross Blue Shield Association level work group, which is chaired by Kim Holland. I'm also chairing an internal work group within our North Carolina plan. I'm also still clinically active. I continue to see patients in addition to my primary role at Blue Cross. Quickly, in general, about our North Carolina plan, we serve close to more than 4 million customers throughout our state. We're in every zip code of all 100 counties. We are our state's largest health insurer. We feel very passionate about the opioid issues because our state has 4 of the cities that are in the top cities in the nation affected by opioid issues. At Blue Cross Blue Shield North Carolina, we've heard this word go around the room about holistic approaches. We do support a holistic, well-rounded approach. We support and endorse the CDC guidelines, both on an association level and a plan level. We also support recent legislation passed this summer called the STOP Act, which Governor Cooper signed into law. Some of the provisions limit initial prescriptions for opioids and requiring providers to check the Controlled Substance Registry. In terms of our local plan efforts, we have analyzed and we continue to refresh our data and analytics, which were developed to understand claims data, opioid prescribing patterns, outlier providers, costs. We have expanded our telemedicine program to include additional codes specifically for mental health. We work with our providers in a collaborative manner. We do view our providers as an extension of our plan. They are the providers' patients, but they're our members. We have provided webinars on CDC guidelines, on STOP Act legislation, on the North Carolina Medical Board, continuing medical education requirements for prescribers of opioids. We have sent numerous letters to providers, educational. We have targeted outlier providers in a very neutral fashion. We have posted blog posts on appropriate prescribing, CDC guidelines. And all of these have actually been well received by providers. As you can imagine, they're out in practice, busy all day seeing patients. So we've tried to create an information one-stop shop for all of them. In terms of member education, our care management nurses have been trained to target members who have opioid dependency or identify substance abuse. They make direct proactive outreach to these members in a way that's engaging rather than intrusive. We've encouraged them to have conversations, not just about, I've noticed you got a prescription for, do you know how to take it? But do you know what to do with your medications when they're no longer needed? Do you know what signs or symptoms are of addiction? Do you know how to store these medications properly in your home? And encouraging them to even have the conversation with the provider as, do I even need an opioid for this? In terms of our pharmacy initiatives, we have an actionable point-of-sale edit message that alerts the dispensing pharmacist if a member is filling both an opioid and concurrently medication-assisted treatment medications such as Suboxone. There are currently quantity limits on all long-acting opioids. We have Narcan nasal spray as well as the self-injectable vial on a preferred generic tier. Prime Therapeutics, which is our pharmacy benefits manager, continues to send quarterly reports to members. Providers, as well as providers, providing information on suspicious high-risk prescription histories. We have partnered with Walgreens Pharmacy, both at an association national level as well as within our state, to have drug take-back kiosks throughout the state. We currently have 20, which will be across the state of North Carolina, and we're providing funds for an additional 22. So our goal is to get these medications off the street and out of bathroom medicine cabinets at our members' homes. Based on our activities thus far, we believe that we have to take a comprehensive approach, starting with preventing opioid misuse and addiction before it begins, improving addiction treatment, adopting stronger integration of behavioral health and pain management, building stronger community partnerships. We believe the public and private sector should work collaboratively to balance standardization of approach while also allowing for local flexibility in developing solutions. We also believe, along with a lot of my colleagues that mentioned this, that health plans need the continued ability to utilize pharmacy management tools and services to monitor and prevent overprescribing and diversion with broader access to PDMP. And finally, just to quickly highlight some of the ways we've worked collaboratively, we've worked on an association level on the substance abuse and mental health work group. We recently went to DC and testified at DHHS to the Senate Finance Committee. We're involved in a collaboration called We Care. We have enlisted our national accounts, labor industry experts. We're using them for dialogue and advisory for primary and secondary prevention. We've worked with the North Carolina Department of Health and Human Services. We served on the Prescription Drug Abuse Advisory Committee. We are on the Payers Council, where key payer stakeholders within the state of North Carolina are coming together to improve health outcomes. We've had several meetings with the Department Secretary of Department of Health and Human Services. We are also meeting with the in-state drug treatment facilities and Department of Health and Human Services to improve treatment within our own state rather than having members go out of state, as well as targeting key entry sites for referrals such as emergency room and primary care physicians. We have worked with the North Carolina Medical Board. They're having statewide continuing medical education panels. We will be serving on those panels. We provided input on the STOP Act legislation I mentioned earlier. We are collaborating with the medical board on how to manage these outlier prescribers. We are also meeting and working with the North Carolina Attorney General's office. We have a meeting again in December to work collaboratively and share our internal work group efforts. Finally, nationally, I participated on the National Appalachia Initiative through the Bipartisan Policy Center under Senator Tillis, where we gathered educators, business leaders, and advocates to come up with innovative solutions for many issues, including the opioid crisis. And locally, we are working on multiple state panels as well as sponsorships to raise awareness, to educate on opioid addiction and opioid use disorder, taking away the stigma, educating our providers, educating our members, and joining forces together. So with that, I'll conclude, and I would like to thank you for your time. And I would also like to say that we would like to continue to partner and collaborate with others, both on a state level as well as on a federal level, in helping solve this problem. So thank you.
Thank you, Dr. Patel. Appreciate your presence here today and your thoughtful remarks very much. Dr. Douglas Nemechek is the Chief Medical Officer for Cigna. We appreciate you being here, sir, and look forward to your remarks.
Thank you, Governor Christie. Good afternoon, and thank you to all the members of the Commission for the opportunity to be here today and talk about the opioid crisis that we've heard killing so many Americans, but also is killing careers, killing families, and killing our communities. At Cigna, as a global health services company that serves 95 million relationships around the world, we've seen the impact that opiates has every day. And we recognized really, as we've heard from some of my peers today, the impact is really threefold that we want to address. First, prevention and education to keep people from getting addicted in the first place. We want to improve care and treatment around pain and addiction of patients who are already sick. And we want to make sure that we reduce and eliminate the stigma around substance use disorders so that we're free to talk about this in our communities the same way we talk about other chronic health issues and chronic disease. Cigna came out 18 months ago and was proud to make a commitment to reduce commercial opioid use by 25%. Within the first year, we were successful at getting halfway there, and we're getting very close to that full 25% reduction already. But that's only the first of our goals. Without repeating some of the things that we're doing that are similar to what others, I want to highlight just a couple of things that we're doing that I think are a little bit unique or different that haven't been mentioned. First, in our partnership with physicians around the country, we've worked to encourage the use and following CDC guidelines, but we've also worked to have physicians sign a pledge with us to pledge to reduce opioid use and join us to start talking about opioid use disorders as a chronic disease. We've had over 270 physician groups representing 65,000 plus physicians sign that pledge to work with us. And then working with them, we've created a playbook of what they're doing in their communities that are best practices around how they work with their hospitals, their emergency rooms, and their physician partners in the community so that we can share that information with other physicians across the country and hopefully allow those best practices to be implemented elsewhere as well. We're working very hard with building our network, too, around making sure access to substance use care is available, growing medication-assisted treatment network by 35% this year, and also making sure that through eliminating prior authorizations for medication-assisted treatment and services, as well as increasing and placing prior authorization on long-acting and short-acting opioid prescriptions, that we're encouraging patients to seek care where it is most appropriate. We're also focused on working directly with our customers who do have issues with opioid use disorder and chronic pain. We've expanded our case management programs such that not only are we sending information to physicians to alert them to their prescribing patterns and patients who look to have high-risk prescriptions, but we're outreaching to the patients directly so that we can engage them and educate them on appropriate pain treatments, alternative pain treatments, and alternatives to the opioids, and hopefully prevent them from ultimately having potential overdoses in the future. Lastly, as we've looked at this, understanding that we can't be the solution ourselves, we focused with partners in the community. We have partnered with Shatterproof across the country and even had 100 of our Cigna employees participate in their fundraiser in Hartford, Connecticut earlier this year. We've also taken steps this year to partner with the Iran and Afghanistan Veterans of America group to try to address some of the unique aspects that in the veteran community across the country, which we heard about earlier today. And later this year, we're opening up a dedicated hotline that will be open to all veterans, regardless of whether they're Cigna insured or not, to help provide support and services to those veterans. So I will wrap up with that. Certainly, we look at this as the first step in reducing opioid supply across the country. It's a necessary step, but it's not sufficient to truly fix the epidemic. We need to provide holistic and integrated care. And as a psychiatrist, I need to add that mental health care is an important piece of this. We've seen the studies that show 50% of opioid prescriptions are written for patients who have a comorbid mental health disorder as well. So we don't want to forget, as we talk about fully integrated and holistic care, the importance that mental health plays. So as we all work together to find these solutions, again, thank you for the time today and look forward to continuing to work with you.
Doctor, thank you. Thank you for your mention on the mental health aspect as well. Dr. Michael Sherman is from Governor Baker's home state, Harvard Pilgrim Healthcare. We welcome you here, Senior VP and Chief Medical Officer, and thank you for your time.
Thank you very much, Governor Christie and commissioners. I represent Harvard Pilgrim, which serves over 1 million members in Massachusetts, New Hampshire, Maine, and Connecticut. We have a strong culture of supporting the community and working collaboratively with all stakeholders. We've all seen the impact of opioids on our members, on our communities, and we really want to be part of the solution. Let me also add, in the way of abusing anyone of stereotypes, I'm a physician. I trained with individuals. I worked with individuals, some of whom are dead from opioid overdoses, some of whom had their careers destroyed. These are people who understood intellectually the dangers. I assure you they were the people who in college were studying on Friday nights, not out partying. So if it can happen to people like that, it can happen to any of us, and we really need to take this seriously. We're actually fortunate that we have in our largest state, Massachusetts, a multi-stakeholder group, the Governor's Opioid Working Group. Through this task force, we're working with all the stakeholders to agree on solutions that can be put in place with clear and coordinated messaging. And again, that's really important. Health plans sometimes are not seen as being the best arbiter of solutions, and by having everyone approach this together with a common goal, we can put these things in place with less pushback. We also operate, though, in 3 other states, and having each state come up with their own practice can be confusing and create deterrence. So we strongly urge the Commission to look at best practices across states and come up with national guidelines that we can all adopt. This is a scourge that doesn't know any state borders. An example of something that we've implemented is actually emerged from the Mass Work Group, which is a first in the nation law, which said that individuals, adults getting new prescriptions for opioids were limited to 7 days for the first fill, and for minors, for all prescriptions. And for anyone, they had the ability to ask the pharmacist for something less than a full fill, and we think we'd like to see that proceed nationally. And I want to stress, if we had done that just as a health plan, I think we would have gotten pushback. Some examples of changes that originated within our health plan. We do cover naloxone without any prior authorization, but we don't just cover it. We've eliminated any cost share because we don't think that cost should be a deterrent to having these medications handy. We also, like many, cover all sorts and all types of medication-assisted treatment, again, without prior authorization. We do cover methadone maintenance, which in many areas is covered through public programs. We thought it important to add it. And when we learned that in some cases individuals had daily copays because of daily treatment, we eliminated the cost share on that as well. We also look at the cutting-edge treatments that are out there. There's a company actually based in Princeton, New Jersey, that has an implanted buprenorphine for substance abuse for 6 months. By implanting, it eliminates diversion. It eliminates people not being adherent. As soon as it came out, we made it available as a benefit to our members. Again, no prior authorization, no restrictions. If people need it, they need to get it. And we all need to be looking at these newer therapies and working rapidly to make sure that our members have access. We've also heard today about the importance of non-narcotic options for the treatment of pain, such as acupuncture to reduce the use of opioids. We cover acupuncture, but we go a step further, and we're actually working with some large employers to create on-site clinics so that their employees have easy access to acupuncture and other types of care. We're also working to broaden access to newer modalities, yoga, therapeutic yoga, mindfulness, et cetera. There actually are published studies that indicate the benefit of those for certain individuals, and there actually are specialists who, in those areas, who work primarily with pain patients, so it's important to make those available. We believe that abuse deterrent formulations are part of the comprehensive solution, but not a panacea. We're reviewing how best to incorporate these into our management approach. And for example, based in Massachusetts Chapter 258, we're ensuring that these formulations of opioids are covered in a manner that does not disadvantage them or make them more expensive than the abuse deterrent formulations. We're also considering innovative contracts with pharma companies that better align incentives with respect to the impact of their products, but are awaiting guidance from groups such as this and the Massachusetts Task Force before moving forward. I would note that there are a limited number of manufacturers making abuse deterrent formulations, so we urge the Commission to provide guidance that will ensure that the products are priced in a manner that makes them available to all who need them. One other thing we do, which is somewhat unique, we have a quality grant fund which goes back many years. Over the past few years, we've tried to focus on medical groups that can use these funds to help address the opioid crisis. An example would be a grant we gave to Maine Quality Counts, which works with many medical groups, and they have a law there that requires physicians to taper those patients who are on high-dose opioids. We gave them a grant to help with education, access to experts virtually, and other resources, training, et cetera, so that they can actually do that. I'm proud to say that thanks to these efforts and those in the community, the number of scripts for opioids per member are down 21% since 2014 to today. Again, that's not enough, and this feels like a balloon where you attack one part, it comes out somewhere else, so it doesn't mean we're even close to solving this, but it does show we can make a difference. Some of the challenges, and these are not new, so I'll be brief. As you've heard, health plans do not have access to prescription drug monitoring programs. I can look them up as a physician, but I can't share them with our pharmacists. Again, physicians are required in many states to query these before writing or filling a prescription. Using this information to help us get a comprehensive picture and determine early on where people are at risk and engage. Similarly, you've heard about 42 CFR Part 2. Again, I would ask the Commission to work to repeal that. Again, that's something that was put in place with best intentions to protect people's privacy. But the reality is that if we have data that suggests that there's a problem, we cannot reach out to a member's primary care physician and make them aware. That clearly is in no one's interest. One other comment I would make is that lack of consensus as to best practices can lead to friction among providers, patients, policymakers, and health plans. We believe that clear guidance from this Commission can really help get us around all of those barriers. And finally, thank you for being here, and I appreciate your listening.
Dr. Sherman, thank you. Some really interesting things that have come out of your work in Massachusetts and New England. Appreciate you being here. Dr. Edward Ellison is the Executive Medical Director at the Southern California Pronante Medical Group. Thank you for coming. Look forward to your remarks.
Thank you, Governor Christie, and distinguished members of the Commission for the opportunity to provide Kaiser Permanente's perspective in helping to combat the opioid crisis. This is a difficult and deadly issue that unfortunately touches us all. I am Dr. Ed Ellison. I'm a family medicine physician who also has the honor of serving as co-CEO of the Permanente Federation. In that role, representing the 21,000 Permanente physicians, provide care for 11.8 million members of Kaiser Permanente in 8 states and the District of Columbia. Kaiser Permanente is a coordinated, integrated healthcare system consisting of a health plan, hospitals, and physicians, all working together in partnership for the benefit of our patients. It's this structure that allows us to provide a comprehensive, strategic, and coordinated approach to addressing complex problems like the opioid crisis. This systematic approach has improved patient lives and reduced the destructive potential of this epidemic in our communities in the following ways. Between 2014 and 17, we decreased high-dose opioid prescriptions by 39%. We decreased brand-name OxyContin prescriptions with their higher risk of diversion into our communities and schools by 75%. We've decreased adverse events in our patients and improved their ability to navigate their lives, with many reporting actually feeling better once they're off the opioids. A summary of our work is available in the peer-reviewed article that we're providing to you. So how did we achieve these results? Our data systems and clinical integration led us to recognize the severity of this problem 7 years ago, and that resulted in the development of what we call our safe and effective opioid prescribing program. Our overriding reason for this initiative was to assure our patients' safety. The cardinal rule in medicine is first, do no harm. We are committed to addressing our patients' pain needs, but at the same time, it's imperative that we do not create an additional and potentially deadly problem for them. Our program consists of 4 elements: patient education, physician education and support, patient safety, and community protection. First and foremost, our patients need to understand the dangers of opioids and with what other treatment modalities are available to them to assist them in managing their pain. They learn that while opioids may be extremely helpful in managing pain, these medications carry significant risk. Education that's available online and in hard copy around alternatives, including non-opioid pain treatment medications, self-care, cognitive-based therapies, acupuncture, Tai Chi, and mindfulness training, and involving the patient in the decision-making process are all critical. We also believe that arming physicians with education and support allows them to confidently provide our patients with the expertise and tailored treatment program that they require. This includes MAT and naloxone. In essence, we want to make it easy for the doctors to do the right thing. We've developed evidence-based clinical algorithms and decision support tools that are embedded in the electronic medical record, making physicians aware in real time of appropriate prescribing and treatment practices, as well as evidence-based alternatives to opioids for pain management. If an opioid is medically appropriate, ensuring the patient receives a treatment plan that consists of the right dose for the right duration, tailored for the particular condition, is essential. It's also about teamwork. Addiction specialists, mental health specialists, pharmacists, physical medicine and rehab specialists, and other experts are just a phone call or an e-consult away. Monthly prescriber-level opioid safety metrics and prescribing patterns are readily available to identify opportunities for intervention and improvement. And opioid utilization metrics are also available on patients to identify, track, and intervene as appropriate for patients at risk for overuse, abuse, or drug-seeking behavior. A more holistic approach has allowed us to taper patients' medication regimens even when starting at high doses. We know that simply cutting off a patient's opioid prescription is not an option, as it may drive them to seek the drugs in other settings, including the street. Opioid addiction treatment requires commitment and forming long-term relationships with patients. By establishing a bond of trust and better understanding the patient's underlying medical, psychological, and social needs, we've been able to incorporate adjunctive treatment options and become a trusted source of help. Kaiser Permanente's mission extends to our communities as well as our patients. We've reduced the prescribing of higher risk of diversion brand name opioids, and we share our successful practices outside our organization and across the community. We also continue to learn and improve. We believe a successful approach requires a strong physician-patient relationship, data-driven evidence-based decision-making, multidisciplinary team-based care, the use of modern technology, and old-fashioned behavior change in an integrated system. We're ready and willing to work with all stakeholders to address this critical national issue. We thank you for the opportunity to share our story and to be of service to those who need our help. Thank you very much.
Thank you, Dr. Ellison. Appreciate that. Fascinated to hear some of the results that you've gotten already. It's very interesting. Dr. Migliori, Executive Vice President, Chief Medical Officer of United Health Group. We appreciate you being here. Large player in this field, and we appreciate your presence.
Thank you, Governor Christie, and to the members of the Commission for the opportunity not only to share our thinking, but for the broader collaboration that your work is going to promise. Our enterprise is very concerned about the impact that the opioid crisis has had on Americans and not just our own clients. And our enterprise is fully engaged in delivering a variety of solutions to meet the objective of, first, preventing the next individual from developing opioid use disorder, and second, to rescue those already afflicted by getting them access to treatments that work. Our prevention solutions are multidimensional and include, first, analytics, using our big data assets to first characterize prescribing patterns. You know, despite the fact that the CDC guidelines have been out for 20 months, only 55% of prescriptions are written in conformity to those guidelines. All right. Yeah. Second, these machine learning has helped us to be able to create our first generation patient predictive modeling tools. We're able to identify the 2% of the population that are going to get where 60% of them will go on to develop opioid use disorder if we don't intervene. And third, and very importantly, getting to General Rosenstein's comments earlier, fraud detection. Fraud is rampant in an environment where people are driven by the disease to compulsive behaviors, and people take advantage of it. We undertook 71 formal investigations in our fraud unit last year and made 384 referrals to federal, state, and community level law enforcement and regulatory agencies based on the behaviors we witnessed. The second thing we do for prevention is at the level of the pharmacy, scrutinizing each and every opioid prescription to look for conformity with CDC standards. Just in 4 weeks, in our initial 4 weeks when we put in the program to show the opportunity, we saw an 82% reduction in first fill prescriptions to the recommended CDC dosing. 82%. That's how much fat there's in the system. This last thing we talk about in terms of prevention is finding alternatives. We've been expanding our already 80,000 provider-strong base of physical medicine people, including physical therapists, PM&R physicians, as well as chiropractors. Because what we found out is when people with such things as back pain, a very common cause to get your first opioid, when people went to one of these docs or practitioners to get their therapy, only 5% of them ever ended up with an opioid for that episode of back pain. Whereas if they went to other specialties, it was over 13.4%. That's 62% fewer opioids for acting in that way, and for that reason, we continue to promote patients receiving alternatives because we think it works. Final thing is the issue about treatment. And let me start off by saying parity isn't just the law. It's an imperative in order to be able to treat this disease. This disease is a chronic disease, much like diabetes and heart failure and the like. The treatment has to be ongoing. And it has to be delivered in a way that aligns with evidence-based medicine. In the case we've used is to build out the capacity and access to medication-assisted therapy, competent people for when it's indicated, and other forms of therapy when other alternatives are called for. We now have some 4,836 locations across the nation offering this, and a 24/7 phone line that will get people in typically within 24 hours for this kind of management. The other thing is to make sure that the drugs that are important for the use, all types of drugs, whether they're partial agonist and antagonist combinations or antagonists themselves, are readily available at the hands so that when that first opportunity to engage one of these patients occurs, it happens. The final thing I'd say is we've seen some meaningful and measurable progress, but there's a lot of work to be done and a lot of new investigation, including opportunities to really look at the PMDP databases as more than just a place to look at cases, but as a place where we could start looking as a patient registry to find best practices. And with that, I want to give our appreciation for being included in this conversation.
Thank you, Dr. McGuire. I appreciate it. Our final presenter before questions from the members of the commission will be Diane Holder. She is the president and CEO of UPMC Health Plan. Thank you for your patience, and we look forward to hearing from you.
Well, thank you. I really appreciate being able to offer testimony today and appreciate the great work that you're trying to do. Pennsylvania has been particularly hard hit, and we're in one of those epicenters when you come up from West Virginia into Western Pennsylvania. I am part of a large academic medical center. We have 40 hospitals and almost 5,000 physicians, cover about 3,000 lives through our insurance infrastructure. And like Kaiser, I think we have the opportunity, because we can work hand in glove between our physicians and our hospitals and our insurance company, we sometimes have a view that's a little more holistic. And be able to share that data and be able to look at best practices. But I think the other thing that's really very important in terms of our environment is that we train about half the physicians in Pennsylvania. We train most of the nurses. We train the pharmacists and the physical therapists. And the incredible importance related to how do we get to the next generation of practitioners to really understand that, yes, pain is incredibly important, and we all have an obligation to use our best science to control pain in whatever way we can, but we have to look at the downside. Before I was running insurance companies, I ran our large psychiatric systems, and so my background is in behavioral health and addiction treatments. And so to me, when I look at what's happened historically in our country, for folks. I remember when the Los Angeles County Jail was the largest mental health center in the country. Perhaps it still is. And I think one of the key messages I would have for the group today is that is the partnership between public health and public safety that has to come together, but in a unique and novel way. So a year ago this month, because we, like you, have been working on the opioid problem for many, many years, we held, our insurance company hosted for our network a large gathering, a large conclave. And we had the U.S. Attorney, who had been very active working with us, the School of Public Health, the medical school, the nursing school. We had federal and state representatives of hospitals, doctors, our insurance company, families who were trying to help their loved ones, and people in recovery. And it was a day of dialogue where we basically just needed to hear from each other in terms of what was missing. And I would say if there was one thing that I think it would be really important for this commission to do, it would be to try to figure out how do you fund communities to come together. And I know there are some grants being issued, but how do you fund communities? Because healthcare is local. Their resources are different from place to place. The epicenters are different. The prevalence rates are different. We are seeing fentanyl as the leading cause right now of what we're trying to get out ahead of. It's devastating. There were 8 deaths in 70 minutes a couple of years ago in one of our counties, just 20 miles from our headquarters. So we are doing what we can, and I would say pretty much the strategies you've heard today, I think are best practices. I think the industry is trying to, look at formularies and look at how you can get in front with, authorizations for certain things. But when you look at what we're dealing with, we are dealing with subpopulations. The reason people become addicted is different. There are different groups of people, and the solutions have to be different for the different subgroups. And that's why I'm saying if you can help local communities with funding, if you can get rid of some of the privacy problems that we have that people have mentioned, and if you can help us come together differently, I think we could do something different and really get on top of this in meaningful ways. So I don't want to take any more time. I would just say ditto to most of the things I've heard here, and welcome your questions.
Thank you very much. And I want to go first to Congressman Kennedy for any questions or remarks he has.
Thank you, Governor. First, let me just repeat that the historic treatment of addiction and mental illness has been a separate and unequal process. All of you as insurers and payers have treated mental health and addiction as if it's something other than the rest of medicine. And so we're in the midst of really a new era, much like when we passed the '64 Civil Rights Act. We had to now begin to implement it and ensure that people are not treated differently simply because their illness is an illness of the brain. I appreciate Secretary Acosta's strong endorsement that parity needs to be strongly enforced. And I want to thank Amy Turner, who's here from his office, who is in charge of that oversight. But as he said, they are ill-equipped to properly deal with that oversight given the current statutory authority. And I appreciate you, Governor, agreeing that we need to enhance that authority in order to be able to hold accountability where it needs to be held amongst many of those who are in this room who are in charge of trying to ensure that that accountability takes place. The fact of the matter is, as Frederick Douglass said, power concedes nothing without demand, never has and never will. And there's a reason why some of these companies in this room no longer have pre-authorization on MAT and fail first. It was because the Attorney General of the state of New York put them into a consent decree. And the fact of the matter is we shouldn't be relying on one Attorney General in one of the 50 states to be really trying to enforce federal policy with respect to parity. I believe, as many of these payers are part of, trying to get clarity on what those common law standards of what falls in, the parity law, what falls out. How do we better define the non-quantitative treatment limits? Because that, Governor, is where the rubber meets the road. We've dealt with the quantitative co-pays, deductibles, lifetime limits, and premiums, but what we really need to deal with now is those non-quantitative treatment limits. The application of medical management practices. Just to reiterate, the law says inpatient, in-network, outpatient, in-network, inpatient, out-of-network, outpatient, out-of-network, pharmacy and ER. They must be compatible for mental health and addiction just as they would for the rest of medicine and surgical care. We need strong analytics, comparability, analytical tools that are agreed to, and I appreciate the support of many in this room, in order to apply those evidentiary standards, as has been said already, in an equal way across all of you as payers, so that there is a bright runway as to what that comparability needs to look like, especially as the field of addiction medicine evolves and as our knowledge as to how to better treat this illness evolves. Let me say, I do not believe the costly inpatient treatment that many of you providers are paying for out of network is the evidence base in most cases. And you're stuck having to pay for it because of parity, frankly. And I'd like to see that per capita payment that you're spending on that inpatient spent on the community resources and supports that will allow them to maintain their recovery with medication-assisted treatment if they have an OUD, which is, by the way, ASAM standard criteria for evidence-based treatment. But we all need to work together. And I would ask Pam, since she kind of represents the association, to talk about the need for those kinds of common law standards that could be helpful for providing that common nomenclature amongst all plans as to what really qualifies as a parity violation per se.
Thank you, Congressman. Appreciate it. And as you know, we were leaders in supporting and getting the passage of the repeal legislation. Thank you. And now our members are working diligently to implement the law and frankly understand the law. There are a lot of gray areas, and we meet with Amy a lot to make sure that we understand and implement them well. But one of the other things that we're working on, because we share your concern that there is not consistency in understanding and implementation at mostly at a state level, frankly, and being asked for different pieces of information, different types of analyses from each state. We're working with the Center for Healthcare Quality Improvement, CHQI. It's a group of stakeholders that are working to try to develop a parity accreditation tool so that we can have that commonality that you're talking about in understanding what we believe is expected of the law and the regulations, and in how we then respond to the requirements.
Well, thank you very much, and I thank you, Governor, for giving me the chance to speak about this, and especially the chance to help represent this commission and follow-on meetings with Secretary Acosta and with Amy Turner. So thank you.
Thank you. I'll turn next to Attorney General Bondi.
Thank you. And thank you for letting me go after Congressman Kennedy, because we share many of the same views. In fact, I have personal friends who are in a pro bono capacity right now suing over parity violations. We've got to work this out. This parity stuff, we've got to work this out. We've got to. We're not going to stop until we do. We need your help on it, desperately. So, Congressman Kennedy, thank you for everything you're doing on that issue. I spoke plenty last time. I just want to say something to Attorney General Rosenstein. I cannot thank you enough. We can talk about this problem all day long. Your guys, the DEA, they're the boots on the ground. They are the ones making the difference in cutting the snake off the head. And I cannot thank you enough for the great DEA agents you have. I think all the governors would echo that. But, you know, we have A.D. Wright, we have Jeff Walsh, we have Jamie Camacho, Bree Sachs in Florida. Second to none. And thank you for what you're doing for the enforcement side.
Thank you, Pam. Governor Cooper. Governor Baker.
I'm okay.
All right.
I have
Professor,
lots of things I'd like to ask about. We'll be here until Tuesday.
Professor Mattress.
I'm just going to fire off a few questions, and anyone who wishes to weigh in, please feel welcome to. Screening for opioid use disorder, is it a requirement for reimbursement if you are going to project and develop measures to cut down on opioid prescribing? Because we are aware that a number of people transitioned to heroin and fentanyl because they were cut off at the source. And so why or why not is there a mandate to require screening for an opioid use disorder before a primary care physician cuts down on opioids? The second question I have is, there is a very good evidence that most primary care physicians are unaware of their patients having overdosed. There is no communication between emergency departments or first responders and primary care physicians that's mandated across the country. And I'm wondering if AHIP and AHA, the American Health Hospital Association, should get together in coordinating that kind of information flow between health insurers as well as hospitals and other first responders. The third thing that I would like to question is whether or not, based on the CDC guidelines, is there a consensus that they are adequate? Having arbitrary cutoffs of 3 days or 7 days has received some pushback from certain medical specialties. Others have said there isn't enough time, there aren't billing codes to explain alternatives, and I'm wondering how the insurance companies would address it. And finally, my final question, and I have at least 8 others, but for brevity, I'll keep it to this. If every major health insurance company and CMS have specific goals, metrics on cutting down on unnecessary prescription opioids, why not have the unified goals? Why are there such disparities between you with regard to what you hope to accomplish, and also how to protect patients who in fact have progressed to addiction? And included in that, in terms of patient protection, is the absolute need for screening for substance use disorders prior to prescribing these drugs, as well as mental health.
Let me respond to maybe 1 or 2 questions. Thank you for asking those. Under 42 CFR, which was discussed earlier, to your point, if a health plan becomes aware of a patient having a drug overdose and going to the ER, we're not able to inform the primary care physician. If the ER is part of their system, they may learn anyway, but if not, they probably won't. So again, we ask your help in eliminating that barrier because we really would like to inform them. One other point, I'll just briefly, you spoke about why do we have different targets. I would love this commission and some of the work groups, and some of this is happening organically, but the states have their own approaches, and everyone is well-intentioned, et cetera. This commission is well-positioned to come out with appropriate targets and measures that we should all work to promote.
So let me add one thing to the targets. From the Medicaid and Medicare perspective, if you look today, right now in Medicare, health insurance plans, health plans are handling about 1/3 of those individuals. They are also handling, in states, probably about 75% of all the Medicaid. So you're right, states may want their own specific targets, but I think for CMS, HHS to set some targets that we could all work together to create makes a lot of sense, because so much of it is government funded, all or in part.
Anyone else want to respond to?
Yeah, I just want to add a couple of things. At Cigna, we have 180, 200 accountable care organizations, primary care groups that we're working very closely with on these very issues. They are begging us for more information on their patients' mental health and substance use disorder histories, and because of 42 CFR, you heard, we're unable to share a lot of that information and data with them. Where we are working with them is, to your other questions, of educating them on how best to screen, how to set up integrated systems of care, either by embedding mental health and substance use professionals in their primary care groups, or bringing that in virtually or from the community to support that integrated and holistic care. So it really is, there's a lot of education and a lot of building of the system to allow that care to occur there in the primary care setting.
I think regarding this, I was just say regarding the CDC guidelines, before we even begin to talk about changing them, we have to make sure that physicians and dentists and providers that prescribe in all 50 states are fully aware of those guidelines and are actually acting consistent with them. I have to say, we recently visited one community in a state that has been devastated by the epidemic, and it was shocking to me the lack of understanding of those guidelines and how, in some cases, poorly enacted they are. It's incredibly important that we start there, and this education piece, beginning in medical school, beginning in dental school, all the way through residency and practice, is extraordinarily important.
And I'll just echo what my colleague said, which is that I think it's important for our providers to understand the CDC guidelines, but I'd also like to say, with my physician hat on, that there's not a one-size-fits-all. So there are going to be patients that will be outliers from the CDC guidelines, and those are entirely appropriate. The key is if the physician understands how to manage that patient, understands how the opioids work, and is monitoring the patient to make sure that they're taking them appropriately, that they're not being diverted, that they're not taking other medications concurrently that would cause side effects. So what I would say, again, along with what he says, is that I think the education piece is important, because when we sent out letters, we had providers not understanding CDC guidelines, not understanding sort of the basics because they were not taught it, number one, and number two, they're too busy in practice to keep up with everything. But there are going to be providers that will be managing patients that will fall out of these guidelines. And that's one of the things that we've talked with the North Carolina Medical Board as well, is that they are meant as guidelines. So just like with opioids, or just like if you were managing a patient's hypertension or diabetes, there might be occasions that you go above what the recommendations are, and it's entirely appropriate for that patient if it's being monitored appropriately by the physician.
Diane?
And what I was going to add is the question around how do we get screening and training. I think we have a tremendous problem in our rural areas where we have a lot of this kind of opioid problem. And one of the things, our state has just received a SAMHSA grant, and they've contracted with us as the primary contractor to basically train the rural communities and physicians in trying to figure out how do you screen. And if you're going to do medication-assisted treatment, which is what we're hoping we can facilitate, you have to help people to train them to do treatment plans. Very few of the current physician community got much, if any, training on addiction in medical school. I mean, it's just not something that was spent a lot of time on. And so we need really to help people learn that. And as we know, addiction and mental health are co-travelers. Depression is often a co-traveler, and we have to treat people and look holistically. So it's not just as simple as an addiction, which is never simple to begin with. It's a really more complicated issue.
If I could just add quickly on the CDC guidelines, I mean, we endorse them. I think to the earlier point, physicians today, studies show that they're spending, for every hour they're spending with a patient, they're spending at least an hour in documentation and in paperwork. So it's an overwhelming amount of work to do to take care of patients. And so we need to make it easy to do the right thing. We need to embed it in their day-to-day life and make it easy to do the right thing and provide access with telemedicine and other resources. It is correct that the guidelines are a great foundation, and there is an opportunity to have an opportunity with telemedicine and other ways to connect specialists and primary care physicians to know when to refer and when to ask for help to customize to that patient.
I just foresee the decline of supply with regard to prescription opioids in the future being a problem that is relatively containable, but the Justice Department's role will increase dramatically over the next few years because of the increase in use psychoactive substances. And I think the insurance companies that are represented here are going to have to take care of patients of a wide range of addictions to opioids, which are derived either iatrogenically or through illicit sources.
I want to turn back to...
One more question is MAT. Obviously, we've got such a dearth of physicians who are trained to provide the evidence base that's going to help us address the immediate crisis of people out there. I'd like to ask the folks here, how do we get the rest of the physician community, i.e. not your addiction folks, but the rest of your physician community to throw in with this crisis and actually train up to be, authorized providers, and maybe do it in partnership with some of your community health folks to help them so that they're not feeling as if they got to take these patients on all alone, but if they have the support, maybe they'll start meeting the need that's out there.
We're training a lot of our primary care doctors to actually deliver these treatments, and we're embedding mental health specialists in the primary care offices.
I'd say the same thing. In our system like ours, we train the physicians, we can monitor, we have metrics to measure, we can again embed it in our electronic medical record, the protocols, the guidelines in real time as they're taking with the patient in front of them. They know they have the triggers right there, the guidelines, and they have immediate access either by phone call or e-consult to the specialist they need. So it's a network that we can provide a lot of support to, education around, so the physician feels supported in doing the right thing.
If I may, I was just going to add, and I think that's an important thing in terms of the support. What we hear from physicians across the country that are part of our networks is we're dealing with very complex patients. And aside from just training in terms of the delivery of the MAT, it is really dealing with the patient themselves that are complicated, that oftentimes don't want to be treated or are resisting treatment. So I think it goes beyond just how to administer MAT and more broadly about the complexities, the psychosocial and medical issues related to these patients that are going to have to be addressed fundamentally.
I just said we have a program on how to have the difficult conversation with the patient. That's not an easy thing to do. And so just training in that goes a long way in making the physician more comfortable.
And you have to have, I think, what you're saying, the team-based care that surrounds it. So, for example, primary care, given the limited amount of time you have in primary care, cannot do this by themselves. And so, I think some of the things that we knew 20 years ago or 30 years ago and how you help people with serious mental illness or addiction, you need crisis treatment teams, you need in-home teams, you need people with addiction specialty to be able to actually be in the community and go to where people are, because it's what you said, people aren't necessarily running towards you to get the care they need, but you'll find them soon enough in your emergency room.
Governor Baker.
So I very much appreciate all the conversation. I was going to pass, but I'm just going to throw out a few thoughts, and if anybody wants to respond to them, feel free. One is next week we have a whole bunch of people from the pain business and a whole bunch of people from the addiction world meeting in my office. To the best of my knowledge, that's never happened. One question I would have for you folks, and this is more of a thought, you should just think real hard about getting the pain people and the addiction people in the same place. They don't talk to each other. They never have. They really should. They would learn a lot from one another, I think. My second thought is we all give out CPACs for antibiotics, 5-day, just take this for 5 days. I think part of the opioid epidemic came about as a result of docs just writing 30 and 60-day supplies for pretty much everything. I would love it if the insurance industry and the physician community would say, how about a 3-day CPAC equivalent for opioids, for dentists, and a lot of the baloney that, frankly, you probably shouldn't give anybody an opioid for at all, but they're still getting them. And even in a state like Massachusetts, where we have a 7-day limit on first prescriptions and a really terrific PMP that, had 5 million inquiries last year and a 25% drop in overall prescriptions, every single day somebody tells me about somebody getting a 30-day supply for something stupid. And I think part of this is if we really want docs and dentists and nurses and everybody else to write 2 or 3 pills or 3 days, we've got to give them a packaging solution for this that works. I don't know what it looks like, but it's just not going to happen if everybody's just doing what they've been doing forever. It might happen by 2025 or 2030, but it's not going to happen before that. And I think it would be great if somebody came up with a solution that looked more like the packaging solutions people did for an antibiotic treatment. The third thing is, 60 Minutes did a thing last week that basically said you lost some of your authority to chase drug distributors and to make arrests and to deliver on your enforcement opportunities. In Massachusetts, fentanyl was about Fentanyl was present about 17% of the time in 2014 in opioid deaths. Now it's present in about 80% of the deaths in Massachusetts. If you took fentanyl out of the mix, you know, our heroin and opioid numbers have dropped like a rock over the past few years. But because fentanyl has sort of come in to replace it, it's totally changed the game. I agree with you. If you don't have the tools you need to tell us what tools you need so that we can make sure they get into the report and you get back whatever kind of authority you need. And that is hugely important with respect to this particular issue. And then my final thing is, in diabetes, many forms of cancer, high blood pressure, mental health, pediatric asthma, asthma generally, across almost every area I can think of that's sort of traditional medicine, people have some idea about how to keep score about whether or not we're succeeding and how we're doing. I would argue that even though I heard all of you talk about evidence-based care delivery, I didn't hear one person say that here's how we keep score on whether or not we're succeeding with respect. I heard a lot about how you keep score about whether or not you're succeeding in reducing the number of prescriptions that get written on the preventive side, right? I didn't anybody tell me anything about how you actually keep score with respect to whether or not your treatment and recovery programs are working. Do you measure 30-day readmission rates? I'm telling you, you know, the amount of people who spin through detox, spin through ERs, spin through this system is mind-boggling. And once upon a time, we used to, when we talked about asthma and we talked about mental health, we talked about some of these other issues, if you had that kind of recidivism, you would say that was a failure of the community-based approach to whatever it was we were doing. And I think one of the big challenges we all face is how are we actually going to define success here? I didn't hear anybody talk about recovery coaches. I didn't hear anybody talk about how long you think somebody needs to be in treatment before you get to the point where you really believe we're being successful. I didn't hear anybody talk about any of a whole bunch of things that if we were having a conversation about diabetes or a conversation about high blood pressure or a conversation about mental health or a bunch of other issues, even mental health, Patrick, I didn't hear any conversation about a whole bunch of things there that would sort of be the part of the conversation that would be, here's how we're keeping score and keeping track of how we're actually doing. And in substance misuse, there is absolutely a failure rate. But nobody seems to know what, you know, where do you draw this line and how do you think about what you're doing with respect to that? And I would actually argue that, and I come from the insurance industry, I would actually argue that by not doing more when people detox and actually head to the community, and I mean a lot more, you are all probably spending more money than you would be spending if you got really aggressive about the community-based approach to care. So that's part of the reason why I didn't say anything, because I figured what the hell, I was just kicking over one can after another if I did.
Let me go to Deputy Attorney General Rosenstein first to give us direct response to Governor Baker's inquiry.
At the time, Governor, I'll be very brief, but I agree with you. We certainly need to make sure we have all necessary tools, and we're working with DEA on that. Just to clarify, that publicity last weekend concerned DEA's administrative authority to suspend shipments of pharmaceutical drugs, so that has not impacted our ability to prosecute criminal violations, including fentanyl. With regard to the issue of how we measure success, I would suggest the primary goal should be to reverse the trend, the upward trend in drug overdose deaths, just to reverse that trend, and then we can focus on bringing it back towards zero. Thank you.
Governor Cooper.
Just one thing, just want to remind everyone, and I know I sound like a broken record, but in North Carolina, 49% of the people who present to our emergency rooms for opioid overdose are uninsured / self-pay. No Medicare, no Medicaid, no private insurance, nobody around this table. Increased access to health care coverage is one of the major steps that we have to take in order to combat this problem.
Any other responses to Governor Baker's discussion? Kim?
Yeah. Well, I'd just like to.
Cogent observations, we're going to call them.
And I just wanted to thank you, Governor Baker, for saying something that although we may not have said anything, I am sure everyone around this room has been thinking and concerned about the very issues and what the standards of care are and how do we measure success in the treatment of people with substance use disorder. I think some of it is, and I'm not a clinician, so there are many wiser on this than me, but what I hear from our clinicians is that much of it evolves around the stigma of mental health, and that our clinical community we are just not as advanced in the delivery of services and, again, in a consistent approach as we are in some of the other medical teams. We've been looking at what happened in cancer, for instance. There was some time ago where we didn't have a means of measuring what we considered success in cancer recovery. We had now we have a 5-year, gold standard, if you will. How could we apply something similar to that in the mental health space? So we are working with ASAM. We are working and reaching out with the AMA. We are talking to certainly the broader clinical community and others to see if we can find an answer to that. We are funding research to look at what happens neurologically in the brain with opioids that's different than other things and what creates such a high degree of relapse. So I think that work is underway. It's certainly going to take more than the blue system, but you certainly articulated well the challenges we all recognize and, again, want to be part of the solution.
Well, I'd say to you also that I think we're seeing, Charlie and Roy and I are seeing at our state levels that, someone said before, there's not a one-size-fits-all. I think it was Dr. Patel. And the fact is that we're defining treatment at times in a one-type-fits-all. And the fact is that what we're finding is that, we have to give a number of different avenues for people to walk down and then give them a tour guide to walk them down that. I mean, this is an extraordinarily complicated set of sometimes comorbidities, and we need to be able to give people the guidance. I think if you talk, and I'm sure you all have, as I have, and as the other people sitting up here have, you talk to families who are in the midst of this. Let's put aside all the different statistics we're talking about and everything else, because those statistics are all sons and daughters and husbands and wives. They are lost. They don't know because we're not telling them what are effective treatment options. We're dealing with a medicated assisted treatment area where you get sent determines what your treatment is, not how you present. You get sent to a methadone clinic, you're getting methadone. You get someplace for Suboxone, you're getting Suboxone. You get sent to a Vivitrol place, that's what you're getting. Regardless of how you present. What other chronic disease do we treat that way? Where, I go in and I'm appropriate with, Charlie brought up antibiotics before. I go in and the doctor says, well, okay, you need penicillin. I say, well, I'm allergic to penicillin. He goes, well, you'll have to go to Dr. Rosenstein because all I prescribe is penicillin. Like, well, hell, man, I'm sick. There's something else, right? There's other types of antibiotics. And he says, well, no, I just don't do that. But go down the street to Rosenstein and he'll do it. Well, if I'm sick and need antibiotics, I probably walk down the street. If I'm someone who's on the edge between relapse and recovery, I don't walk down the street. I give up often and go back to my heroin dealer or my fentanyl dealer. And that's the part of this that I think is enormously frustrating for families. And when I hear the discussion of MAT, which I think is a useful tool in all this, we're not requiring the medical community to use it in the way that we require them to use every other medication, which is the patient presents, you make an evaluation of the patient, and what is the most appropriate medication for that patient. Instead, they go into Rosenstein's office and they're getting Suboxone, and they come into mine and they're getting Vivitrol. And that's just unacceptable. It's unacceptable to be dealing with it that way. So I think, part of this is we need to acknowledge and come up with a plan for how we're going to get people onto the right road and then have someone who walks them down that road. And I think Governor Baker is right. Paying for that, rather than perhaps blindly paying for 30 days inpatient or 60 days inpatient or 120 days inpatient, may wind up costing you a lot more doing that than if we became a little more nuanced about this. Dr. McCleary.
To both you, Governor Christie, as well as to Governor Baker, I fully agree with what Governor Baker has said. In fact, in a research unit that we have in Governor Baker's state, we have a group that's working on building out what that dashboard needs to be. Because so far, what we have available are process measures, we need outcome measures, and the outcome measures is death. All right. To get to the point of being able to measure that, so I was so encouraged by what the commission is already focusing on in terms of broader uses for the DMP. That can become a patient registry to do just what you're describing, Governor Christie, which is to be used as a place where we can track the success of each individual who's treated, so we can start looking back as what was the process of care for this individual that got us to success. That's the only way we're going to be able to answer the question that Governor Baker came up with, which is how long do they need to be in therapy? Well, they probably need to be in therapy lifelong right now because we don't have proof to say that they're done. The other side of this issue is with the PDMP, it would look very much like the success that American medicine had with pediatric cancer, where every child was treated on a protocol and they were tracked. 90% of kids nowadays who have cancer are treated on these protocols. 95% of them are cured. And the reason is because we went to doing registries. And your focus on PDMP I think, is a very big step in getting there, and I would encourage it.
Can I also comment? Again, I think these points are dead on, and particularly about the way we're keeping score. Governor Baker is right. We need to do better. Let me also share, I've been on more than a few committees that look at measures. In Massachusetts, we've had the statewide Quality Advisory Committee, which looks at measures. And we talk philosophically about the fact, we've got to do better with behavioral health. We have to do better with the substance abuse. The problem we run into, and this is worth further dialogue, is we have a lot of smart people who want to get it right. So you start scoring it by things like, does NQF have validated measures or NCQA, et cetera? So the fact that there aren't validated measures and they're not agreed upon becomes a barrier to doing anything. You end up going in circles saying it's not ready for prime time because we're trying really hard to make sure that what we do put out there is fair to all the stakeholders. So I think it's worth thinking about how we can use that to promote better measures. Similarly, AHIP did actually a successful endeavor probably about 2 years ago, where they brought together not just insurers, but professional societies. CMS was there, and we together looked at many areas as a group. It took many meetings and over a year, but it was a good process. And what we came out with were measures for various areas that everyone agreed were the right way to measure results in progress in those, whether it is orthopedics or primary care, et cetera. That might be a good venue for doing something similar, looking at the questions we're asking. How do we tell if we're doing a good job at treating substance abuse? Because I think we need a major effort, and that needs to be a major part of what comes out of this committee.
I look at pediatric asthma. When I was working in government in the 90s, pediatric asthma was a gigantic problem for your health service program, your Medicaid program. And when we finally got everybody together to start talking about it, one of the things we said was, well, what's one obvious measure? How many times does a kid end up in a hospital who has asthma, which is theoretically treatable, and how many times do they die? Okay? Now, the data originally, when we started collecting on this, was horrible. But the good news was we actually had a place to start. The problem I have with a lot of the conversation around this issue in particular is I sort of feel like there's no place to start. I mean, I look at the state's data, the Medicaid program, and the spin that people have who are dealing with substance use disorder are mind-boggling to me. And but at least we collect the data, which gives us a place to start. Now, the goal then becomes, well, how do you get better? And the answer is you try things. And if you find things for certain people who present in circumstances that work better than others, you chase them. But I'm telling you, the lack of community follow-up and community support for people who are dealing with this when they come out of whatever kind of secure residential inpatient type setting they're in is a big part of the reason, in my opinion, why they just end up back in there again. And that's one where maybe we can push the folks who do a lot of federal research around this area to do more. But it's also one where some of you have data sets that are definitely big enough where you could create a baseline and then try things and see what happens with respect to what moves the baseline.
I was going to say, I think that part of the dynamic is we're coming out of an era where addiction and depression and other mental health conditions have not been considered chronic illnesses, and we haven't built a treatment delivery system that has the full continuum of care appropriately in communities, and the reimbursement for most of those services is very, very low. We have some whole counties, half of a state that will have no child psychiatrist in them at all. And we've been working on a project for years where we're trying to bring down the multiple antipsychotic dosing that's going on for kids under the age of 12. And we have outcome measures, and we look, is it going down? Every single year, is it going down, and under what circumstances? But it's extremely challenging because we do have a reimbursement and a paradigm problem, in my opinion. But I think it's changing, and I think the only good thing I could think about this whole tragedy with the opioid problem is that it's actually raising these questions, and commissions like this are existing. We didn't have this much before.
So, Governor Baker, we got to stop people dying. And I honestly don't care how they do in recovery if we can give them the opiate replacement therapy that'll keep their brain from craving and will stop their brain from overdosing if they take additional drugs. We know how to do that. Now, that may not be optimal for that patient. That's when we start the recovery process and hopefully get them to where they have stability and life skills. But as the Attorney General said, this is a matter of trying to stop the overdose deaths. And everybody coming in with an overdose ought to automatically be put on this and monitored. We got to stop the deaths. That's our outcomes right now. I'd like us to, unfortunately, we've had this abstinence only has been the metric for recovery. And that's another thing that, Diane, we have to get past and not think of this as just in the 12-step model, although that I think has been crucial to recovery. But first, let's deal with the medical aspect of this, which is the craving in the brain, and get that treated. And tragically, we don't have enough doctors who are prescribing this treatment, and so there's not enough people gaining access, so there's people dying. We ought to be treating this like a FEMA response and getting the necessary medication. If this were Ebola, we would be getting it out there to every practitioner in this country. We'd waive all the rules and we'd say, get it done and start saving lives. I mean, that's what we need.
That's what we've been saying.
I agree with Congressman Kennedy completely, but I think there are three issues that I think are major weaknesses in the current status. Number one is, in some states, about 75% of people are dying alone. And the problem is there is a vast number of people who are unidentified, either through the healthcare system or otherwise, unmotivated to present themselves, and there has to be creative ways of figuring out how to rescue those people, foremost from death, and then to enable them to get into treatment. The second issue that I think is really critical is that outcome measures and record keeping amongst the 14,000 traditional treatment centers are very weak compared to the healthcare system, which has much stronger records over the century of keeping records and keeping outcome measures and implementing evidence-based practices. So I think the weakness is not only that we don't even have guidelines on what the outcome measures should be, but we don't even have accountability from treatment centers that get government block grants in terms of measuring how many people relapse, how many people continue treatment, and so on and so forth. So record keeping as well as effective quality measures and standards of care have to be improved dramatically.
Any other comments from that? Dr. Ellison?
Good thing she's got the pen with respect to the
Yeah.
report, don't you
Yeah,
think?
yeah. It's a good decision.
I was just going to comment on Congressman Kennedy's comment, and that's why it's so important to shift from abstinence to harm reduction, right? So that's really where the focus has to be, harm reduction.
Well, I want to thank everyone for your candor and for your preparation and your willingness to expend your time here today. We appreciate it a great deal. You know, in the time that we've spent in studying this since the president appointed the commission, and many of us have been working on this issue. In fact, every one of us who's sitting up here have been working on this issue in our own states and our own disciplines for a long time. You know, we knew that today was going to be a key part of this. In the end, we're not going to be able to deal with this problem effectively unless you all are partners with us in this. I said the same thing to the pharmaceutical companies. If they're not going to be partners in this, not only in terms of a reduction in the type of prescribing that's happening and all the rest, but you know, the brain power that exists in the R&D operations in all of our major pharmaceutical companies are going to be the folks that are going to come with more MAT, are going to be the folks who are going to develop more non-opioid pain medications so that the necessity of using these in any instance will be diminished significantly. And so what I would hope you're going to see from the report that we'll issue in a little less than 2 weeks will not only be a recitation of the problem and where we are, but it's going to be, so you're prepared, a real call to action for all of you. And that's not to say that you're not acting now. We've certainly heard from all of you today about the things that you are attempting to do and in some instances succeeding with. But when 64,000 people died last year, it's not enough. And I heard you all say that too. But we now have to turn those words into action. I think for any one of the governors up here in particular, we're the ones who are confronted, I think most frequently, in the states by the families that are affected by this epidemic. And I can't tell you how many roundtables and meetings I've held with those families who are completely at a loss. They've not only lost their loved one, and so many of them have died, but also for those who are still alive, they're at a loss with them too. And this epidemic is one that, you know, I remember, and everyone up here is old enough to remember the AIDS epidemic. And I still have not seen the passion for this epidemic that I saw in the AIDS epidemic.
I agree with that.
It's just not there. I say to these families all the time who come to see me, I said, where are the marches? I remember the marches on state capitals and this capital demanding that these drugs be covered by your companies. And before the drugs existed, demanding that the pharmaceutical companies develop the treatments that would change this from a absolutely sure death sentence to a chronic disease which is now being treated. And so we can't wait that long in this one, because while there were certain isolating factors involved in the AIDS epidemic in terms of its ability to be spread, those isolating factors do not exist in this one. They don't exist. And so we're going to be looking at 64,000 deaths in 16. I don't know what anybody thinks the projection will be for 17, but I'm sure no one's predicting it'll be less. It's going to be more. It's just a multiple of how much more. And I wonder how much more pain the people in this country are willing to accept and not blame us, first and foremost in elected office, the healthcare community for not taking this seriously enough and in some instances profiting from it, and the health insurance industry from being the payers of the people who are profiting off of it, along with whatever profits you're making as well. I'm a capitalist. I want everybody to make profits. I think it's great. But we can't any longer go about addressing this problem this way. So anticipate a report that will incorporate many of your suggestions, but will also place new demands on all of you that go beyond what you testified to today. And I hope you're prepared for that, and I hope you're prepared to accept the challenge, because we know that if it hasn't got into our own house yet, it could. And then all of a sudden your perspective on this problem becomes markedly different. So I want to thank Professor Madras, Attorney General Bondi, the governors, Congressman Patrick Kennedy. We'll be back here on November 1st. The meeting on November 1st will be focused on testimonials from those families that I'm talking about, from the individuals and the parents and the spouses who want the people of this country through this commission to hear what it is like to live through something like this happening to someone you love. And I would urge everybody who sat around this table today to get on that live stream on November 1st. Because if you're not motivated by anything else, I guarantee you, and I think the guys on either side of me will guarantee you as well, you'll be motivated by listening to those families. They'll be the ones who will call you to action even more than any government agency, because they look just like you. And so I hope you'll join us in one way or another on November 1st, and I thank you all for being here today.